So this is the video of acute appendicitis in a paracolic position. So I am doing a laparoscopic appendicectomy. So this week we are going to see paracolic position of appendix, simple case and difficult case, and this is the simple case. So as we make a 5 mm camera in umbilicus, so we are making a all quadrant abdomen view before making another port. I couldn't see the appendix, maybe it is in the paracolic. So that is the bladder, that is the suprapubic area port entry. So the port will be at the pubic hairline and we enter a little bit obliquely. So it is a suprapubic port, 5 millimeter. So I am shifting the camera from umbilicus to the suprapubic port. Now you can see the view. So it is a base of cecum and ileum is seen nicely. So that is the developmental adhesions. So that is the cecum. Now you can see the appendix is lying parallel to the cecum and ascending colon. So this is a paracolic inflamed appendix. So another port will be at right iliac fossa, just below the level of IC junction. So camera in suprapubic, right iliac, this port just below the level of IC junction. So this will become a working, left hand working, umbilicus is a right hand working, camera coming from the suprapubic port. So that is the appendix, you can see. So the mesoappendix is facing towards the right side. So we have to sometimes edematous acute, it will be difficult. So just I want to show the various position of the appendix in each video. So this is the paracolic position. So I am dividing the mesoappendix with the harmonic scalpel. Always any energy device you can use to divide the mesoappendix. Don't divide with the bipolar. Usually bipolar is not recommended to divide the named vessel. The named vessel, the pressure will be more like a cystic artery, appendicular artery like that. So we used an energy device. Otherwise you have to use a clip and then bipolar artery. Bipolar coagulation you can use it. Since I have a 7 millimeter port in umbilicus, most of the appendix I will take with a 7 millimeter port. So I am going very close to the appendix. If it is not possible, then I convert into 10 millimeter, but most of the time 7 millimeter is adequate to take out the appendix. So we have to rotate and then see the because the mesoappendix is not facing towards the umbilicus, it's facing towards the right lateral wall, so that the vision will be a little bit difficult. Suprapubic you can get this vision. From umbilical port, the paracolic is very difficult to see because totally opposite side. So vision will be very difficult in paracolic position if you keep the camera in umbilical port. So almost I reach the base. So that is the base of the appendix and cecum. So as usual, hold the tissue covering the appendix, not the entire lumen. So I am holding the tissue so that the lumen of appendix is free. I am milking it out. Don't hold the appendix, full thickness of appendix and then milking it out. So that our aim is to move the content of the appendix towards tip, so that we can apply base loop to the base. So it should be exactly at the level of base, and usually the three tinea will join that level. So we should not include the cecal wall also. Cecal wall also should not be included. So we have to mobilize the appendix correctly, and then you have to apply the loop at the base. So once you apply loop, and you can check whether it is applied correctly, or sometimes if you put little bit above close to the appendix, then second loop will be at the level of base. So I'm milking it out again. You can see I'm holding only the fat covering the appendix, the mesoappendix where I'm holding it. So this is not a good technique, and applying loop, I told you yesterday, last video, that thread should not touch the appendix when you tighten the loop. And so now you can see I apply the second loop at around 2 mm gap between the two loops. Second loop you can tighten very nicely. And we have a study that studies that supportive evidence that we can apply hemlock clip to the base of the appendix and then you can divide. So I'm just checking the distance. You can see the 5 mm instrument is so big, and then the distance between the two loop is so less. So it is a 1 to 2 mm the distance. So the tip is a little bit thicker, so it will not come to the 7 mm trocar. The mesoappendix also edematous there. So I'm dividing the mesoappendix so that I can take the appendix, try to take it with the 7 mm, so avoiding the 10 mm incision at the umbilicus. The standard teaching is we have to apply another loop around a centimeter away from the previous loop, and then you can divide so that the content of the appendix will not come out when you are taking it out. And then the loop will, third loop, we should not divide. So the loop will be holding the appendix, even if a accidental slippage of appendix with your instrument, slippage also the loop will hold the appendix. So we are not practicing that, but that is the teaching, standard teaching. So I'm taking out the appendix through the 7 mm port. The fat also I'm taking it out. So this is the betadine gauze piece applied to the base. If you feel the knot is little bit loose, you can tighten now. So these are other procedures are standard like all other videos. So only thing I just want to show you different position of the appendix. So everyone should know appendix is not in the same position in all patients, and common is a subcecal, then retroileal is the second one, and then third one will be the paracolic, then retroileal, retrocecal, and then subhepatic. So all variety I am going to show in this series. So that is the paracolic appendix. Not much bleeding or any content is coming out. So anyway, giving nice wash is good. They are giving wash like this, particularly in the diaphragmatic, subdiaphragmatic area. The carbon dioxide will be there, so that will become a carbolic acid, and then you are taking it out, so that the postoperative pain, shoulder pain will be less if you are giving a wash to the peritoneal cavity. So I am going to the suprapubic, pelvis, and from suprapubic port you can see it's very well we can show the pelvis. and the suction is from umbilical port. Colon sigmoid or rectum is retracting from the right iliac port. This is the view from suprapubic port to the pouch of Douglas and pelvis. One surgeon asked in a comment and he said the good view, so it's definitely will get a very good view with the suprapubic port. You can able to see all quadrant by keeping the camera in suprapubic. So this end of the surgery. Thank you so much.